All right, hello everyone, good afternoon. It is 4:05 and we are going to start without my co-moderator. And Dr. Klein can come join us up on the panel here. Thank you everyone for joining us for this last session of the day, Femoral Popliteal Revascularization. And we will start with our first talk. Yes, Dr. Sethi giving the first talk.
Well, thank you for having me. Happy to present my case, and thanks you for sticking around for the end of the day. I'll hopefully make it worthwhile for you. So we're going to talk about an SFA CTO case post-EVAR. And for those of you who were in the previous session, it'll be a nice little segue from radial access and some of the benefits to it. The disclosures are online. So this is a 76-year-old man, history of CABG. AAA, and he had an EVAR done about 3 or 4 years prior. He had CKD stage 3 with a creatinine of about 2.5, and so I think that plays a role into some of contrast limitations, and we didn't always take pictures of every single step for that reason. He had severe bilateral claudication, life-limiting, started at a few steps. He was otherwise very functional and really wanted a better quality of life. We did a ABI which showed right side was 0.78, left side was 0.81, and there was a right SFA occlusion and severe left SFA stenosis. This is his duplex. On the right, you can see that the stenosis starts really right after the bifurcation, the occlusion, I should say, and then he has reconstitution in the distal segment. And here's his anatomy. I'm going to go back just for a second because I was playing. And you can see here, go back 2 more. So you can see here that the heavily tortuous, and this was at the time of his left side intervention. So you can see quite a lot of tortuosity, and everybody looks at that picture and starts groaning. And you understand why the up and over approach may not be ideal in this kind of a patient. So we ended up starting left radial. We took a JR4 and a glide wire used to cannulate the descending aorta, exchanged it for our 150 PV multi-curve. And usually we use the R2P 119 or even 105 for patients that we're looking at SFA to land in the common femoral. But because of all the tortuosity, we lost a lot of length. We actually needed the 149 catheter. So you can see here now, once we had our sheath down, you can see a peripheral angiography, and you can see that similar to what we saw in the ultrasound, the occlusion started right below the profunda bifurcation, the reconstitution in the distal segment. What was interesting is that once you use a 149 Terumo sheath, your options in terms of crossing catheters and other devices do become limited. I think that plays a role into how this case unfolded. We did try initially antegrade. We didn't have a whole lot of success. Switched to retrograde. He did have 2-vessel runoff on the duplex, and we felt pretty confident on our ultrasound evaluation. We used the AT successfully. We had wire escalation, and were finally able to cross the distal cap using a stiff glide wire and navicross. However, when we reached the site of the proximal cap, we were in the subintimal plane, and we really didn't want to dissect up into the common femoral and risk jeopardizing the profunda artery. So at this point, we again turn our attention to the antegrade approach. The only catheter at that time that was available in the 200 length was a Viper cath, which is what we used with the Stato 40. We were able to finally cross in and get into a subintimal plane. We then did rendezvous via card and then snared out the Stato from below and then swapped it for a safer wire and did the rest of it with an externalized command wire from the radial out the AT. We then dilated with 6.0 balloons, and then we used, at that time, we used Sapara stents to cover the area that we had dissected and re-entered. And so this was our final angiography here. And the patient's symptoms are resolved, and he did much better. We had 2-vessel runoff at the end.
Sanjum, can I ask you a question here?
Yeah.
On that Sapara stent, the ostium, it's a great stent. You usually can't get it. Did you deploy that from your retrograde axis? Because you had to, really, to nail that ostium, right?
Yeah, that's exactly correct, right? Because we didn't have the lengths with a 149 sheath to be able to deliver pretty much anything from the radial, aside from the Masago stent, would be the only one that would have reached from there. We wanted to use something that either had the properties of a Supera or was drug-eluting. So we did go retrograde and then sort of nail that ostium and then bring it down. So. Yeah, so this was right before Alluvia came out, which is why we used Supera. We didn't use Zilver. And the other issue is that the Supera is on an 018 and the Alluvia is on an 035. And sometimes coming retrograde, the Alluvia's had a little bit of a hitch for me coming retrograde. Because again, we had to deliver everything retro. So that was the other sort of consideration. But certainly I think Alluvia could have really been used in this situation probably. To summarize, alternative access can be used alone or in combination to approach complex lesions, and sort of piggybacking off of the conversation from the last session, I think radial sometimes is paired with pedal quite nicely and able to accomplish things that you can't accomplish using one alone. And then you certainly want to be facile with the entire toolbox. And you want to, I think we continue to need development in shaft length so that we can deliver more things radially if we so choose.
That's a great case, Sanjum. Let me answer or ask you a question regarding how'd you close up your DP access?
So we just used Terumo bands for both the DP and the wrist. We don't routinely do like dry closure, but I know some people do that.
Yeah, some people come from above and put a little balloon on, but obviously you're not going to come from the wrist and come all the way down.
Yeah.
That's nice.
So even if you couldn't have crossed, even if you could have crossed antegrade, you still were going to have to go retrograde there because you didn't have the length, especially when you saw the angulation of that EVAR and everything. It's long enough to get down to the distal SFA. Then you add that angulation. It swallows every bit. So you were determined to go. I mean, you were committed to going retrograde no matter what. Is that correct?
Yeah, I think that's why we sort of quickly went retrograde up front. I mean, maybe we should have started that way, but we did switch over very quickly because we realized that we weren't going to be able to accomplish this all from the wrist.
And it was invaluable because you had to cross the proximal cap from above, from antegrade. So you're going to need both anyhow.
Yeah.
And was there any option of going antegrade from the femoral, or you just don't like to do that, or it's too big of a patient, too short of a distance?
Yeah, that was a feeling that just based on the pre-imaging that we had, that it was so close to the common femoral, to the bifurcation that weren't going to have that much of a running room. But certainly if you really kind of took an angle, it was just, we didn't think we had enough running room, honestly.
Very, very interesting case. Oh, I have this problem with the button. Which way does the button go? Oh, there we go. Okay. Great case. I'm just wondering, amongst the panelists, in these cases where you're not going to obviously go up and over, and antegrade is not easy, does anybody just primarily do pedal access? Just do everything from the foot right at the get-go?
I personally would not go right from the get-go. I want to be able to come from above and below, especially in the case of what Chris was saying and what Sanjum said. I want to dissect up through the CFA, and then we got bigger problems. So I think you got to have something from above, one way or the other, either going brachial with a really stiff wire to try to straighten all out, like a Safari or something, or and then coming from below.
Yeah, I think there's so many ways you can't see from below because you're trying to nail the ostium with a stent. You got to nail it. If you start getting, like you said, to the common femoral and you go and you don't know where you're going, and you do not want to re-enter in a bad place in the common femoral, as a surgeon, you know better than anybody. So I think visualization from above is super, super, super important. And ideally, at least an access like you did, Sanjum, of at least penetrating the proximal cap from above, and you could visualize. I think you had to have access from somewhere above.
Any thoughts?
I don't have much to add to that. I mean, I agree. I wouldn't solely come from a retrograde approach. So
I'm always amazed at people who do everything from the foot. There are people who are skilled and do everything from the foot, and I am just amazed at that. But great case. I think the bidirectional approach, antegrade and retrograde, is huge. Whether you come from the arm, or sometimes you can do a steerable sheath to just get something around but you always worry about that flow divider. You don't want to mess that up. The flow divider, okay, but when you have the kissing iliac stents, that can be really treacherous, even with the steerable sheath. So great case. All right, we'll have our next speaker, Dr. Aronow.
Hey, everybody. Okay, so I was tasked with presenting a Popliteal CTO case. Disclosures are online. It's a 71-year-old who has the usual risk factors, including diabetes, HFrEF, prior cabbage, who comes in with a left lower extremity that has pain at rest and a hallux ulcer. This is a patient who had the onset of lifestyle-limiting claudication about 6 months prior, and then 6 weeks after that developed a wound on the great toe after having his nail trimmed. He was referred by podiatry for possible revascularization. You can see the non-invasive vascular studies focused on his left lower extremity. On the right of this slide here, you can see that his ABI was 0.42 and TBI 0.22, and you can see how the waveforms flatten as you move distally. So this is an invasive left lower extremity angiogram. You can see that there's really not any substantial disease in the common femoral or at least the proximal and mid SFA. But on the right, you'll notice that there's an occlusion just above the knee in the pop. And reconstitution, you'll see in the tibioperoneal trunk. And there's just a still frame focused in on that. All right. So I think there are a number of questions that we probably need to address at this point. What access for the intervention? Are you going to go ipsilateral, i.e. antegrade? Are you going to go contralateral or up and over? And then what about the lesion? Are you going to come from above in an antegrade fashion or below in a retrograde fashion? Are you going to decide up front that you're going to use some kind of rendezvous technique? Are you going to approach this with a guide wire and support catheter, or do you favor crossing and reentry devices? Are you going to try to stay true lumen, or do you already know from the get-go that you're going to go subintimal? And what are you going to do if this initial approach fails? That is, what's your next best option? How are you going to remain flexible? Where would you move your base of operations to? And then finally, what are your adjunctive therapies? And maybe we don't know enough yet to know that. And what would your definitive therapies be? So I'll pause. I realize maybe you don't have enough information to answer all those questions, but maybe a good point to have the panel weigh in.
So Herbert's a great case. I think what I would do, first of all, I would prep the foot from the beginning so the staff knows we're thinking that way, and there's a reasonable chance we're going to go that way. You could go either antegrade or contralateral because you can reach with any equipment from either direction. I would try to cross very carefully in an antegrade fashion. You've got a little bit of a nub that you could see, and I'd make sure I obliqued it away from some of the geniculates and some of the others. But I would not go subintimal from above. You have to stay in the true lumen above the bifurcation of the perineal and posterior tibial artery, I think. So if I could get there, which I think there's a reasonable chance you can, great. If not, I would then go from retrograde and come up and rendezvous somewhere in the middle where you've got more options, but not at the end at the distal bifurcation. And then I would start low, gentle balloons or low pressure balloons or focal force balloons, and then work your way up from there.
Yeah, I agree. I would definitely try just slightly, maybe an 014 pilot wire, some CTO wire, and then work my way. And if you can get in, awesome. If you can't, because sometimes sometimes it just flies down. And then you got to worry about thrombus. But I think then coming from below is a great option here. And then I would then IVUS, so you know what vessel size you're dealing with, and then try to work your way up slowly and steadily up in terms of sizing balloons.
And Herb, before we show, we've got a surgeon right here. So you've got, if the SFA is good all the way down, is it a short bypass from the distal SFA to the tibial if that was needed? If, let's say you can't do this, tell us the surgical options if you would.
I actually, for this patient, seeing the popliteal occlusion, I would work him up for a bypass. And if he had good vein, I would try to do a bypass, even if it's short and a good target. So if it's a good vein and a decent distal target, I would probably try to do a bypass. Now, if there's no good vein, I think all bets are off, and I would definitely try endo rather than do a PTFE bypass to a tibial. But you could, looking at this, probably do a bypass from the distal SFA to a tibial.
So let me ask you this, Shirling. So he had prior cabbage, as I mentioned. Let's just say theoretically that he had good conduit despite that. Would you try this first from an endovascular standpoint and then failing that later, then bypass if you didn't burn any bridges, or do you think you will have burned your bridges?
I think if he were a good surgical candidate, like cardiac-wise, he was like, I realized he had cabbage, but in my mind that means their coronary disease is fixed. So, he's revascularized. If there's still some good vein, if he meets all criteria for a bypass, I would probably try to do the bypass first. And generally that works out well, but as we'll see in subsequent talks, bypasses go down, and you can always try to recanalize the native system later.
Yeah.
I would go endo first, carefully, and not do anything stupid.
Yeah, other thoughts from the audience? Peter, Subhash, would you guys do anything differently?
I agree. I think starting with endo is probably the good way, and I love that you use the word base of operations. I think that highlights where you need to meet, which I think is critical in this case.
Yes, a question over here.
I think the amount of tissue loss, if it is minor tissue loss, so our aim is to get this patient healed. So probably going endovascular, which may last for a few months, to allow this minor tissue loss to heal, probably this is wise. Otherwise, if he has a big tissue loss from the beginning, we can think about a bypass.
Remember, he had breast pain also, right? Meaning that if his wound heals and that closes down, he may be back to rest pain again. Well, let's keep going unless anybody else has any suggestions or different thoughts. Try that. There we go. Okay. So the approach selected was antegrade with anticipated wire escalation, and then, if needed, reentry. And if that didn't work, then you talked about retrograde. The idea was that we'd come retrograde at that point. So antegrade access was obtained with a 6 French 55 centimeter Rafey sheath, and then an 018 quick cross was used as the microcatheter with an 018 Fielder XT and an 014 Fielder XT and an 014 Estado. So the Estado was placed, you can see on the far right panel, into the AT, which was occluded, and then using a parallel wire technique, after confirming we were in the true lumen using IVUS, placed a second wire, the Fielder, into, let's see if we can get this to go forward. That's just IVUS. You'll see in a moment that we placed a second wire into the perineal. But I think worth highlighting two things from the IVUS, and again, maybe stressing why intravascular imaging is so critical with these cases. One is, I think you can appreciate the degree of calcification and at some levels concentric calcification, and therefore the need to plaque modify. Therefore defining your adjunctive therapies, but also just the size issue, right? What size devices are you ultimately going to need for your definitive therapies? If you look at angiosizing of the tibioperineal trunk, you would have said it was 2.8, and by IVUS almost a millimeter larger. If you looked at the POP, you would have said it was just over 4 millimeters, and by IVUS about a millimeter larger than that. So I think it helped a lot with this case. I got ahead of myself, but what you can see on the far left panel here was wiring with that Fielder into the perineal. And then ultimately, with that second wire anchoring into the anterior tibial, there's a 4 millimeter balloon inflation performed in the POP. So what now? Based on what you know, I guess what you know now that you didn't know before is that there's a lot of calcium in those vessels. So what's your next step here?
I think you need an angiogram to tell you that next step. And, this is one time I go a little more conservative with the first balloon. And that wire, that second wire, looks like it's getting resistance right there. Is it? Or is it just
the one in the perineal?
the perineal?
I think right before it before it knuckled maybe, but
Gotcha.
yeah,
Okay.
I don't think, I mean, you'll see, I don't think there was any issue with the perineum.
I'm thinking IVL here, personally myself, based on that IVUS, and I agree, go low first and then kind of work your way up. But based on that, at least a 5, if not a 5.5, maybe even a 6 at low pressure.
Chris, can I push back and ask, you've got IVUS images, what do you want to see in the angiogram?
Please, you got to see it. You take the balloon out and show me. I'll go do iris as well, but this plumber needs an angiogram right now, and then we can supplement that with an iris on a smart map. But I just think it's going to give you so much information before you choose your next step.
Okay, fair enough. Other thoughts?
Yeah, I would definitely get an angiogram here too. I feel like it's unfair to ask for next steps without an angiogram at this point.
So that's fair. I don't know that I included an angiogram, so you'll have to trust me that it made us want to go ahead and do IVL. Let me just back up for a second, sorry. So that angiogram on the far right is actually post-IVL. So on the left, what you can see is IVL with an M5, 5x60, and then below the knee, you can see IVL with an S4, 4x40 to the POP and TPT respectively. And then on the far right, you can see the angiogram after doing that. So now what?
So I would like to see the angiogram before, but so you now IVUS is you're going to have to potentially IVUS. And one of the things that makes your life a little more difficult, not only is she wiggling her leg, I assume, but when you go antegrade, you don't have the profunda, or excuse me, the profunda collaterals, and sometimes the flow makes it look a little worse than it is. But there's something going on downstream, whether it's a propagated dissection or distal embolization. And do you have a picture below that? I'm sorry to keep asking for angiograms, but
Yeah,
it would help me put the pieces together in an oblique angiogram that include a little bit more downstream, because it looks like the anterior tibial artery
It's gone.
is gone. And that can only happen with a dissection or thrombus. That's where your IVUS Herb is going to help you a lot now.
So the AT, is that what you just said? The AT was gone at the outset.
Yeah, but you guys got into it though.
Just wired it. We never.
just wire, okay.
The AT was chronically occluded, so you are ballooning over your TP trunk wire.
Correct.
Is that correct?
Correct. Well, let me skip ahead in the interest of time. A Supera 5x120 was placed across the POP into the TPT, and then using IVUS guidance, a coronary DES. This is prior to the availability of purpose-built below-the-knee stents. So this was a 3x38 coronary DES that was placed distally all the way into the proximal perineal. And there you can see inline flow through the POP into the perineal. You can see a continuation of that flow and then some collateral filling of the AT and PT. And then you can see, obviously, there's quite a bit of disease distally at the level of the foot. So what would you do now?
Well, I'd say that now seeing the outflow, I wouldn't really be excited to do a bypass on this patient. I mean, I think you can do it. You can do a bypass to the perineal, but usually you want to have like robust collateralization of the DP or the PT or something in the foot. So I think endo approach here is probably a good idea.
Can I quote you on that?
No.
Yeah. So I would say one thing that you glossed over this quickly, but you did it absolutely correctly, but an important point for the audience. If you're going to put a Supera and distal to that, put a drug-eluting stent, you must do it in the order that you did it. In other words, you got to put the Supera in first and then add the drug-eluting stent. Why? You've got a little stent there. Remember the mechanism of delivery of a Supera is that nose cone ratchet over, gets sent forward. It will mangle a little 035, or excuse me, a coronary stent. So the way you did it, Herb, was spot on. I'm not sure you're not done. I mean, you've got pretty brisk flow. It was a tiny wound to begin with.
I think you're done, Herb. I wouldn't deal with that PT. That's going to be a nightmare to go down there and try to recon. You're going to have to get across that whole thing. It's small. It's diffusely diseased. I bet you're fine for now.
So that was the end of the case. The wound healed fully in 4 weeks. The rest pain resolved, and patient at 20-month follow-up had patent stents. So key learnings for the operator and team. CLTI is optimally managed. I know we didn't talk about it, but I feel like I have to emphasize this. This is straight from the guidelines, and it certainly was true before the guidelines were written, but CLTI should be optimally managed in a timely fashion and through a multi-specialty, multidisciplinary approach. Upfront planning is integral to procedural and long-term success, and intravascular imaging can inform procedural technique and favorably impact outcome. Thanks.
Great talk. Thank you very much. Next, I want to invite Dr. Banerjee up to give his talk.
Thank you. My topic is femoral popliteal artery stent fracture and occlusion. I want to emphasize the contributions of my team in putting together this presentation, and hopefully it'll be evident. Feel free to critique it. It is not yet published. So this is a case that Dr. Rosol, my partner, and I did, and Chris Metzger was the live moderator in the year before this at SCAI. So this is, I won't give you the entire story, but this is a 40-year-old, very young lady who presented with critical limb-threatening ischemia. She has various comorbid conditions, including vasculitis, which is medium vessel vasculitis. And initially, she underwent a left lower extremity endovascular intervention in 2021 for a heel ulcer. I moved fast through this. This is an occlusion, as you can see. It was treated with initially DCB, and then 2 overlapping stents, self-expanding stents, were placed with good result and very good 2-vessel runoff, at least. This is the subsequent contralateral intervention of the right lower extremity SFA, where initial treatment was done with a non-stent approach. You can see after crossing the occlusion, IVUS confirmation. And then a limited amount of stent was placed, and the rest of it was left. And some part of it was left with balloon angioplasty. And at that time, the patient also had the left lower extremity intervention imaged because her symptoms had recurred. And this is what we actually observed. Zach and I game planned this, and we're bold enough to try and do it as a live case. And I'm not saying that these are unusual cases. We had a plan, but crossing stent fractures can be very, very difficult. And we had planned for a retrograde and antegrade approach. And you can see the entire stent has multiple fractures with displacement and most likely pseudoaneurysms in the areas of the fracture. For those who want to refer to this, this is the classification from Dr. Aida in Japan that we follow for stent fractures. This is a type 4 stent fracture where there is complete transverse fracture with displacement. I hope you agree. And this is the CT angiogram to show the corresponding nature of the disruption of the architecture of the stent that inertly and intimately relates to the formation of the pseudoaneurysm. I'll let you scroll through this for a few moments. And this case has started a finding of stent fractures and other mechanical complications of stents in the lower extremities within our registry. And I want to highlight this as we go forward. The crossing of the stent was a little challenging, but ultimately we were able to cross it. And then after balloon angioplasty, we were able to put a covered 7mm Viabon. I was trying to put a little smaller. I remember Chris pointing it out to IVUS it again and put a little larger, and I think that was the appropriate call. And we achieved good success, and the patient has done really well. But this is the case that actually has led to deep dive into the registry's angiograms. And the first point I want to make is that that stent fractures are far more common, and the reason we underreported because we do not know the denominator. And the typical posterior anterior views of most angiograms preclude from diagnosing the frequency of stent fracture accurately. So this is a case. I provided the dates with patient IDs from my team, which shows clearly the progression of stent fracture in this patient. This is that same. This is another patient who had a undisplaced fracture, and you can see between the two durations of time, in 2 years, there is significant displacement. And I will also want to show and prove it to you that fractured elements of stents actually migrate. That means that if you place it precisely in the distal popliteal, like you suggested, it could actually end up far below or far above from where you envision them to. The combination of stent fracture, long occlusion, and heavy calcification makes for, in my opinion, a term that I use is called hostile SFA. I view in-stent restenosis cases of the femoral popliteal and below the knee actually extremely hard cases. Just because you can see the vessel, treating them is very, very difficult because a posterior anterior view does not do justice. And once a stent is placed, not just crossing, but actually re-establishing an appropriate lumen becomes extremely challenging. And one thing I have seen in the registry not to be done, that if the stent doesn't expand well, please do not put a balloon expandable stent in it. That is a recipe for real serious problems. Retrograde, I don't do much medial thigh punctures. This is one area where I actually do it when there are stent fractures and I cannot cross them in an antegrade fashion. Again, this is a very difficult. Now, pay attention to these cases of stent fracture and migration. Panel A shows the location of the short stent that is marked in yellow within multiple layers of stents. Look at a different date in 2013 to 2014 where that short stent has actually migrated down the SFA. I don't want to detail all the history, but these are old stents with multiple stents placed within stents. And I think the mechanism here with IVUS was that the previous stent was less expanded. So when you put a second stent, there are areas of migration, areas of apposition and areas of complete malapposition that requires that can facilitate migration of stents and movements of stents. And you can see the distance that stent has moved is quite remarkable. Precision placed stents in the SFA ostium. I want to tell you that there is nothing called precision placed stents because this stent has moved up in relationship to that secondary branch in the common femoral artery by at least 4 millimeters, and now it covers the ostium of the profunda. And I can tell you there are many more cases than this. The reason we have selected this cases very precisely is because these patients have to have a reproducible angiogram with an identifiable branch, not the anatomy or the projection that allows you to measure the precise movement of the stent. So we have been very particular with this approach. Look at this stent fracture and stent migration. This stent was definitely below or just at the level of the profunda. Now it has moved reasonably around 4 millimeters above and moved closer to that branch and completely now covers the profunda. So all of these things that we are talking about, stents in the common femoral, in the ostium, I think these things need to be relooked and re-imaged and reassessed in the spectrum of things. Now, this paper is in progress, so I won't be able to give you all the details, but this is a comparison of 392 patients from 6,400 patients that have got core lab adjudication within the registry. And reason these patients were selected is because the XLPAD registry does not require repeat angiograms. But if patients have had repeat angiograms and they have been submitted and they have a reproducible landmark from where the stent migration could be measured, these are only those select cases. So it is not an incidence. This is just a reporting proportion of cases because I do not know the denominator. But in this documented cohort, 14.3% of these patients had stent migration, and these were randomly selected. So I had no control who did repeat follow-up angiograms. And we did see a significant difference in the degree of migration between CTOs and non-CTOs. And the initial results do not show any difference based on atherectomy or lack of atherectomy, but there is an early difference detected between subintimal and true lumen approach. So with a greater migration if the stents were placed proportionally in the subintimal space. So with this, let me draw you to the conclusion that it is an uncommon finding in caveats, quote unquote, as we do not truly know the denominator. It is thought to be approximately 5%. However, CTOs and subintimal stentings are associated at least with increased risk of stent fracture with this preliminary observation with stent migration. And the adverse effect of stent fracture and stent migration does not need to be repeated, and they are shown. I've provided the QR code to look at it, and of course, want to say not just thanks, but significant gratitude to the rigorous amount of work my team has done in establishing protocols to measure this, and hopefully this will set standard for adjudicating such studies in the future. So thank you. Happy to answer any questions.
So Subhash, I gotta bring up that perhaps many moons ago in a galaxy far, far away, we actually did this study in normal patients with SFA. We actually put wires down and looked at and published this in CCI Medical Physics. The amount of foreshortening that occurs, and we all see that. We put quantitative analysis onto it. I think we underestimate how much the SFA not only moves, compresses, and has translational torque force. And I'll reference you to that paper from CCI from 2009, I think. But the reality is that there's so much going on there, and we used it by putting in wires in these side branches and literally just turning your leg from straight to cross-legged like this. The amount of change that happens is massive. And I think we all underestimate doing that. I mean, I remember at one point people were doing this on the table like, oh, what happens? Maybe we should put this. That's not going to change what you do if you have to stent. But I do think, have you seen any of those in the Supera stents? That's what I want to push back. I want to say, have you seen any movement with Supera?
I intentionally stayed away from branding the stents. But yes, it is much less frequent with Supera. But also the representation of Supera in the registry is actually also very small. So that's why I want to emphasize the denominator or the lack of it. But yes, we have seen it.
So, Subhash, again, one more example of the excellent data and information we're getting from the Excel pad from you and your team, so thanks. The one common denominator here, and this is what I beg the audience, is long nitinol stents that are overlapping, especially when you overlap them by a lot. My plea to everybody is it's easy, I get it, to put a long 200 nitinol stent and then add another one. It's easy, and your AP angiogram looks good. You're not doing your patient a favor by putting that much nitinol stent in general. So you should avoid, I think we should avoid that. If you're going to have to stent that long, then use the Supera stents, which don't fracture and bend with your leg, or a Viabond stent if the case is indicated. And you're not immune from that by putting a drug-eluting stent because it's still nitinol. So please, I mean, it's easy, I get it. And go click, 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 and everybody smiles. But you're not doing patients a favor, in my opinion, to do long nitinol stents.
Yeah, I had a few comments and a question. So first of all, it's so interesting to me. This was really great work. So congratulations to you and your team, Subhash. Just, the ability to predict who's going to fracture, right? I think that's fascinating. And why in some patients that fracture do you end up with pseudoaneurysms and in others you don't, right? And you may not have the answer to that, but I'll just put that out there. I think the question I was going to ask you is, given the degree of stent migration that you've observed, and given how often we have to stent up to the ostium, we think we nail the ostium of the SFA, do you think that the norm for the common femoral bifurcation should actually be similar to the norm in the left main, where we're frequently using two stent strategies, even when one of the vessels may not actually have functionally significant stenosis? Should we be stenting into the profunda too?
I mean, my gut feeling is I would avoid it. That's personal, but I want to reinforce one thing is that the area of the stent fracture is not close to the anatomic bend points because the superficial femoral artery laying in the adductor canal has connective tissue connections, and vascular surgeons know more than that. And MRI studies from Stanford have shown that the actual area of kinking of the artery or movement is independent of the bend points or joints. So if the artery gets fixed in the distal part, and you stent more in the mid SFA, that then becomes the most mobile part of the artery. So the mobility of the artery migrates with the adhesion of the artery along the adductor canal. So it's a very complicated thing. But I do think that, I always say that I tell myself that the crossing strategy determines the end strategy. That is why if you work it backwards, you can think that I can't elucidate all the facts, but it makes sense how to approach an artery and make the initial forays, because the final outcome will be dependent by the first movement you make in treating a complex long lesion. So,
A comment or question from the audience here?
yes. And just introduce yourself so we know.
Sure. Raj Tanwani from Tulsa, Oklahoma. I was wondering if you've been able to tease out if drug-eluting stents are more likely to migrate than bare metal stents, because bare metal stents will have more scar tissue and endothelialization, fixing them in place maybe.
At least an empiric view, we don't see the difference, and that is why I put the timelines. Whether it is drug-eluting or bare metal, the amount of adhesion of the stent with the neointimal coverage should be pretty adequate if it is 2 years old. So stents are still migrating when they are 2 years old. And I think serial studies would be important, but at least at the preliminary superficial glance, it doesn't seem to be that there are any predictors. We do see much less of it with Supera, numerically. Sanjum.
Yeah.
Sanjum Sethi from New York. So my question is, clearly you have to deal with it when there's stent fracture causing restenosis, thrombosis, pseudoaneurysm, et cetera. But sometimes we'll do these angiograms and we'll see stent fracture that usually is a type 1 or a type 2 that seems to have flow through it. So how should we be managing that? It's always a dilemma. Should we cover it, not cover it, balloon it, et cetera?
And I didn't read it aloud, but that was the third point, that if you do see a fracture, first make an effort to find the fracture if you're doing a follow-up angiogram, even if there's great flow. And if there is, then there may be some way that we can study of longitudinal follow-up, not necessarily with an angiogram, but maybe with other ways where we can detect the progression of that fracture or the lack of flow or progression of restenosis. So that's what I would suggest, standing here without great evidence. Sorry, go ahead.
And after that, we'll get one more. And this gentleman has been patiently waiting over here. So Peter, when you're done, pass the mic to that patient gentleman over there, please. Go ahead, though, Peter.
So we know from Dirk Scheinert's paper from 100 years ago with the Festo study that calcification was one of the major predictors of developing stent fracture. I wonder if you could comment on that. And the other question is, when we identify these stent fractures and patients have pseudoaneurysms, we really don't have a lot of guidance in terms of what should we do about them. I mean, if it's a small pseudoaneurysm and the patient's stable, I mean, is there a risk of rupture? How should we be managing these pseudoaneurysms when we identify them?
I think that is a good question, and we can identify some of these cases from the registry. Your twofold question would be that in our 394 patients, we actually looked proactively for calcification as a predictor. We didn't find it. Our biggest predictor was chronic total occlusion stenting and subintimal. And of course, we are going to delve into it. And I outline the limitations of this analysis. The second question is that pseudoaneurysm, in my opinion, if it is iatrogenic after stent placement and there's a fracture, I would be obliged to cover it and treat it rather than observe it. Of course, the size matters, but I think that when there's a displaced fracture, especially type 4, and the relationship of the struts of the fracture truly aligned with the pseudoaneurysm, I think that those should be treated more proactively than simply observed. They are more likely to cause
So
problems.
Subhash, pass your mic to our patient colleague here for the last question here.
He is Tarek from Case Western.
Thank you. Great presentation. Two questions. With this stent migration, was IVEST used, and do you always oversize your self-expanding stent, and were they oversized? And number two, if you have a stent fracture, especially the grade 4 and 5, depending on the indication, would you have a lower threshold for bypass rather than putting another stent?
Tarek asks many loaded questions, which I humbly cannot answer because I do not know. But I have one proactive suggestion. His site is an active participant in the registry, and I encourage his team to enroll more patients into the registry. I think we will know more, but I do think that IVEST-based imaging, I made a subtle comment that the crossing strategy, the pre-dilation, pre-treatment strategy, the imaging strategy, all of these wills layer on each other to achieve a result where either there is limited stenting, no stenting, or avoidance of fractures and or migration of stents. So I'm sorry I can't give you a precise answer, but that is a work in progress.
Great. All right, well, next we'll move on to our moderator, Shirling Tsai, who's going to talk about management of occluded lower extremity bypass. Shirling?
Hello. Okay, good afternoon. I'm going to talk a little bit about managing occluded lower extremity bypasses. I think he still has the clicker, though.
It is in my pocket. Whatever people give me, I tend to put it in my pocket.
I know. All right, great. I have no disclosures. So before we talk about occluded bypasses, which we talked a little about yesterday, a couple things about bypass graft surveillance so we can avoid the problem of the occluded bypass. So this is a case of a patient, 58-year-old man who initially presented with left foot ischemic rest pain. He underwent left SFA stenting, which resolved his rest pain, but then 2 months later, the stents occluded. He came back and we did a Fempop below knee pop bypass with ipsilateral reverse saphenous vein. And then he stepped his toe, ended up with a wound, got an open amp, and at that time we got a CTA, and the vein bypass graft was widely patent. It was wide open, anastomoses were wide open, distal runoff was good, and he did fine from his open toe amp. He finally showed up 5 months later for his surveillance duplex, and interestingly, he had elevated velocities. I don't know if you can see the number, but it's like 500 in the common femoral, and elevated velocities in the proximal anastomosis, and elevated velocity at the distal anastomosis with all of this spectral broadening. Anybody who does vascular lab reading, you can see all of this is filled in here. This is not generally a good sign. And then, also very concerning is the low velocity. This is a velocity of a 30 in the middle of the graft. So these are all bad signs of a threatened bypass graft. It was patent, but it was definitely a problem. So we actually got a CTA the same day, and you can see that he has exactly what we saw on the duplex. The anastomosis, the stenosis right here in the common femoral inflow at the proximal anastomosis and at the distal too. I didn't get that picture on the CTA. So we took him the next day for intervention, and this is the initial angiogram, which just shows what we saw on the CTA. Plus, here's the distal anastomosis. It's stenotic right here, right before the distal anastomosis. We were able to treat both of these with drug-coated balloon. There's the final result for the proximal and for the distal, so it looks much better. He was actually asymptomatic from this, so had he not had the surveillance duplex, we would never have found this. And I think this case points out the importance of bypass graft surveillance for these bypasses, because primary assisted patency for these bypasses is actually very good. So depending on where the distal anastomosis, where the target is, the patency for a vein bypass graft is probably 60 to 70% at 5 years. And the primary assisted patency, meaning if you can salvage this bypass graft before it occludes, is very close to that. However, secondary patency, meaning if you go try to salvage the bypass graft after it's occluded, is not nearly as good. I usually tell my patients once the vein bypass graft goes down, the patency of that is probably as good as a piece of PTFE. And for those, I probably quote 50 to 60% at 2 years. So I think very important to do bypass graft surveillance so that we are not in the boat of dealing with occluded bypasses. So here's an example of an occluded bypass, 68-year-old man with a non-healing right TMA after a right SFA to below knee popliteal bypass with vein for popliteal aneurysm. So important point, popliteal aneurysm, because I actually ligated. This is one of those cases where we ligate the native artery because we want to prevent embolization from the popliteal aneurysm. I ligated the popliteal artery above and below the aneurysm, so really there is no option to recanalize the native system here because it's been ligated. Anyways, he had his surveillance duplex and he had a very severe stenosis at the distal anastomosis, but the bypass was patent. So we held his Xarelto for 2 days and booked him for an angiogram, but in the 2 days of holding his Xarelto, his bypass graft went down. So we went to shoot the angiogram, the bypass was occluded. So we shot the angiogram, at that point we stopped, talked to him about doing a distal redo bypass, revising this, and he refused. He did not want to have another bypass. So here's the pictures from his angiogram. You can see the SFA is open and then the bypass is out. We took him, since he refused a redo bypass, we took him to recanalize this bypass. It was a end-to-end, proximally and distally. So we took him to recanalize the femoral, the SFA to below knee pop bypass. This here, you can see a little bit of the bypass here. We got across it with a wire. Here's the confirmation angiogram and distally, so outflow is intact. He hadn't trashed the outflow, and actually his PT was really good all the way to the foot. So in recanalizing this, we got across it and did a thrombectomy with a penumbra. And then if you look here, after we did the penumbra thrombectomy, there is still some problem at the distal part of the bypass. This is what had the elevated velocities on his surveillance. So because of this, and knowing that there's probably still residual thrombus throughout this entire bypass here, I actually relined the whole thing with a long Viabond. This is a 25 centimeter Viabond, basically converting this from a vein bypass to a PTFE bypass. And this is the completion angiogram. So this is what so it is possible to thrombectomize and salvage these bypasses, but as I said, the secondary patency is never as good. This configuration stayed open for about a month, and then it occluded, and then we took him back to do a femoral to tibial bypass with contralateral reverse saphenous veins. So vein bypasses can be thrombectomized and salvaged, but important to consider surgical revision if you already know that vein bypass is kind of marginal. And then one more.
Shirling, before
yes.
you do that, those are great cases.
Yeah.
I know Herb had a question from the first one. I've got one from the second.
Yeah.
Can we pause for that?
Yeah, we actually don't need to talk about the
these
third
are great
case.
cases.
Yes.
So Herb, you had a question.
Yeah, I had three.
Yes.
So my first question is just, can you give us your perspective on why the distal and proximal anastomoses fail in these grafts? Is there a vasculopathy that predisposes patients to this? Are there technical factors to the operation that can predispose somebody more so? So that's the first question. The second is, what's your threshold for surgical revision of these grafts versus approaching them from an endovascular standpoint when they're still patent? And then the third, and I'm happy to repeat these if you can't remember all three at the end. The third is just, do you think that we can extrapolate, that it's fair to extrapolate the approach to treating asymptomatic grafts that are found to have issues during surveillance follow-up, right? Can we extrapolate that approach to endovascular interventions in patients without symptoms? Is it fair to go back and always re-intervene?
Yeah, so to answer your third question first, because I remember it, we actually do surveillance for our bypass and our SFA stents. So we surveil them a little bit differently, a little less frequently than the bypass graft, but we still do surveillance duplex for out to might be 5 years now. 2 years, it's about 3, 6, 12, 18, and 24 months, and then once a year out to 5 years. And even if the patients are asymptomatic, if we find a high-grade stenosis there, which we will say for our vascular lab, we define it as greater than, I want to say greater than twice a velocity, increase in velocity greater than 2 times the one before it. That would be equivalent to greater than 50% stenosis. For that, I would either do another bypass graft, another duplex, like 6 weeks later, or just take them to do an angiogram or get a CTA. But if there is a high velocity there, we'll go and do an angiogram and intervene on the SFA stent, even if they're asymptomatic. Sort of treating them like the bypass graft. So, for this one, I think for bypass graft stenosis, most people would treat these with balloon angioplasty as the first line. And so I have several patients where we've balloon angioplasty bypass graft stenosis, and you can go do this a couple of times. I have one patient where we actually put a coronary stent into the bypass graft, but I think at some point when you've gone over a couple of balloon angioplasty and bypass graft to salvage the original bypass graft, then you have to think about doing the surgical revision. And then what you use for the surgical revision depends on the patient. Like if they have a more saphenous vein, like contralateral saphenous vein, I would use that to do an interposition graft after you've tried to balloon angioplasty the stenosis a couple of times. I think, the most common places to get bypass graft stenosis is actually the proximal and distal anastomosis, because that's where you'll get intimal hyperplasia. That's where you have the suture line, that's where intimal hyperplasia forms. There's always some turbulent flow there. Those are all the reasons why. The distal anastomosis is probably the most common place for bypass graft failure. And so when you do that, technically, for people who want to know about this, technically, it's actually really important to see the whole suture line come in and see the toe of the graft so that you are not narrowing it, because that's the common problem of these bypass grafts. So always look at the proximal and distal, and you can always, from these duplexes, you can learn a little bit more. If the flow is really low through the bypass graft, that is an indication that something is going on, something is not right in that bypass graft. Yes.
I had a question, a second one. My opinion, my experience, if you have an occluded bypass graft, just like an occluded Viabon, if it's acute limb ischemia, you got to treat it on the spot. Otherwise, that's the one time I think thrombolytic catheters make your life a lot easier. They get rid of all that clot, and usually you can focus on the problem, which is, as you said, the distal anastomosis, and that can usually be treated pretty well endo rather than a graft revision the first time around. What do you think about lytic catheters if they're not acute limb ischemia?
Oh yeah, I think definitely. Actually, that patient had already thrombosed that graft before, and in the previous rendition of this story, we lysed it. And then this graft had been kind of petering along for a while, and we highly recommended bypass graft revision, but he declined that a couple of times. But that distal anastomosis, I think, was the culprit. I mean, in this case that was presented, he could well have had a lysis catheter. He was not acutely ischemic. He had this non-healing wound, but a lysis catheter would have been totally reasonable there. I decided to do a penumbra thrombectomy, but in the end, you could still see the problem, which was the messed up distal. Actually, the distal aspect of the vein graft was I think had been balloon angioplasty so many times and was severely scarred, and that I think led to everything failing recurrently.
You know, Shirling, on a lot of these IVUS, when you do IVUS of these anastomotic lesions, they're neointimal hyperplasia and pretty aggressive. Of course, we're like, well, we don't want to put a cutting balloon there, we don't want to do that, we don't want to cut the suture. Is that a real scare?
No, I've actually done it. I use the angiosculpt, but people do cutting balloon there. I think you can't do it immediately after, though. You have to wait. There has to be some time. I can't tell you exactly how long it can be, but if this is, a couple years out, people do undersized, very much undersized cutting balloon. And then I think the drug-coated balloon, the DCB, is probably a good idea there, because this is intimal hyperplasia, and in theory, you would think that would help a little.
What about drug-eluting stents?
So I've done that too. There is actually a paper from Hopkins about this, using drug-eluting stents in bypass grafts to salvage the bypass graft. And I think after a couple tries of balloon angioplasty, or even one try of balloon angioplasty, if you have recurrent stenosis there, if you're trying to balance between doing an interposition graft to salvage the bypass versus a coronary drug-eluting stent, either one is reasonable. Other questions from the audience? Yes.
If you have a bypass graft and your duplex velocities have increased, you did make a comment that the type of flow changes your management plan. So do you think that CTA intervening before angio or CTA can provide similar amount of information, or you get more information by taking them directly and doing an angiogram?
Yeah, so I think, for the bypass graft surveillance, we do mostly duplex. It is, it's presumably faster, and it's probably less expensive, and it's less radiation, less contrast. Question, I think, is it worthwhile to get a CTA after you have the duplex? In this case, I don't think so. If it was just purely in the bypass graft, just elevated velocities in the bypass graft, or elevated velocities of the SFA stent, I don't routinely get a CTA to check for that, unless the patient is like a terrible patient for access. If I know the access is going to be really hard and it's a question of whether there's really stenosis there, I'll get a CTA to try to avoid a difficult access and a difficult angiogram. But in this case that I showed, he had elevated velocities in the common femoral, which I didn't really understand. I didn't understand why that was. So that's why I got the CTA to look for the inflow problem there.
Great.
Other questions? So I'm going to skip the last case and ask Dr. Rosol to come and give his talk.
Nope. Yes, yes, there it is. Perfect. Okay, great. Ooh, echo, echo. All right. Turn that down a little bit. There we go. Okay, so I was tasked with talking about non-dilatable Fempop lesions. So I have a couple examples. We'll poll the audience and the panel about what they would do, and I'll show you what I did as well. So to get started, so what's the issue, right? So the tough part is that all these vessels are heavily calcified that we see. We all see the popcorn calcium everywhere, and we either need to go through, around, or over that are the options that I see it, okay? So going around is being facile and using reentry devices and understanding complications or pitfalls with those. Going over it, Shirley just very well and eloquently outlined some of the challenges with bypass, but it's something that needs to be considered as well. And going through it, as outlined throughout the last 2 days here, is really dependent on adequate lesion preparation. So, without further ado, here's an 83-year-old gentleman who's had prior stents in his SFA. He has peripheral neuropathy, and he now has Rutherford class 4 rest pain. You can see his severely reduced toe pressure of 20 bilaterally and reduced TBI. He's been intolerant of cilostazol and has elevation pallor in clinic, so we opted to take him for an angiogram. Never a great sign for the up and over, right? Tortuous iliacs. And so here's his runoff on the left leg. So you can see his prior stent. He's got a mid-SFA occlusion that's actually just distal to that stent. He's got adequate reconstitution in the usual distal SFA and has occluded tibial vessels after his TP trunk. So this is from that up and over approach. Our wire escalation strategy is usually starting with an 0.14 wire and escalating up to 0.35 with the use of a 0.35 support catheter. So we were unable to penetrate that cap. I'll stop there. How would you guys change your strategy at this point in time? I'll show you what we did. Peter, you got it? So we stopped here because I was up and over. And we have to think about deliverability of equipment, right? And so I showed you how tortuous his vessels were. The pushability and the ease of delivering anything up and over is not really facile there. So we stopped. Go ahead.
So Zach, what do you think there? So you're digging in the same spot, but if you look, your loop is pretty big, right?
Yep.
You're in the stent, it looks like, but then your wire, that loop of the wire is way up towards the top of the screen and off the top of the screen. Is it worth just pulling your catheter, redirecting it, and trying some more?
I can tell you I tried all that.
What's that?
I tried all that.
Huh, okay.
So
Did you switch to a straight?
Yep, I used a straight tip glide
just try to
wire as
burrow
well.
it in? Okay.
I tried to just use bare catheter, the tip of the blunt tip of the Navicross, and was unable to penetrate the cap. I think the biggest challenge here was the loss of pushability, trying to be an up and over through the tortuous iliacs.
And one other crazy question. Did you ever get a look at the angiogram after somebody put that stent in? Because if somebody put a stent into a subintimal plane,
could be there
and you
too.
don't know that,
No.
if it did, and sometimes if you don't have the angiograms, you can at least ask the patient, and when they say, I never felt one bit better the day I left, in fact, I was worse, then somebody may have stented right into a subintimal plane,
It's
which, by the way, we got one in Columbus referred to me last week, and look and think, come on, man, that's out in the subintima. And that'd be another cause to at least look at.
I don't know that. It was done years ago at an outside state.
The other option is really hard what you're doing around that up and over is you use balloon-assisted tracking and bring down a 90-centimeter sheath right into this thing. And sometimes I'll put the sheath like
Right at the tip of it to
dilator
add
right
more.
into the thing and use
Yeah.
the dilator to poke through.
So instead of trying to balloon assist it down, we just brought him back and went antegrade and did exactly that.
Yeah.
So we brought the catheter, an antegrade sheath right down to the
You know,
end.
one other thing that just, Zach, one other thing maybe to try first is, we do have some devices now that can be helpful in this situation. So like a reflow medical wingman or BBAC catheter. Because typically what you have with these huge calcified caps is your wire is going to just naturally want to go to either
Deflect
side
it
of it.
around, yep.
And so something with a centering mechanism that can allow you to just kind of punch it straight in the nose and hopefully get a toehold in the center of that calcified plaque, like a wingman or a B-back, might be another potential option here before necessarily committing yourself to doing this really long, painful, subintimal calcified recanalization.
Right. Those are great points. We unfortunately don't have those devices at our institution. So we brought them back. We went antegrade. We brought that cap, the sheath right down under the cap, as you said. And with the sheath sitting right there, we used an 035 wire and the Navicross again, and we were able to penetrate around it.
Can you inflate a balloon to center the wire and use a stiff wire to puncture through, similar to what he was saying, but inflate a balloon and to center the wire and take a stiff wire and puncture through?
We didn't try that. That's a fair point. I felt like being able to penetrate successfully through that heavily calcified plaque was not going to be very favorable, and we were probably looking at a subintimal anyway. So, but even the fact that we were able to, we couldn't even get subintimal next to it initially was the challenging part. So here you can see we are clearly around the plaque. Okay, so we take another picture and now we try to re-enter. And with using 014 and 018 wires and even an 035, we were not able to re-enter with just a wire strategy. So we tried an anterior device. So anterior is a balloon, right, with two 180-degree oriented side ports and a very stiff wire. So you're visually looking for a low calcium area if you're doing this, okay, to try to penetrate and re-enter. And my partner was unable to do so. So we brought the Pioneer device then. And so Pioneer is IVUS guided re-entry, right? And so we use the needle, throw that needle into by orienting the IVUS catheter, and then here you can see that we re-enter in and are able to then exchange out the Pioneer device and bring our 035 Navicross back in, and now we balloon and stent. We did not, we made an attempt at fixing his outflow and getting across the popliteal lesion. We couldn't. Knowing this was rest pain, we stopped just to reevaluate his symptoms, and his TBI, his toe pressure did go up to 45, and he had resolution of his rest pain and was able to walk some more, so we opted not to go back for a repeat revascularization at that point in time. Would anybody else go back and try to open that up, the outflow better, or would you stop here if his symptoms improved?
Zach, I was just going to ask you if you imaged or considered doing any kind of intravascular imaging before you stented after you recanalized.
We had the Pioneer device in, so we were able to, we had the ultrasound there for vessel size, but we were subintimal. We knew that, and we had decent balloon expansion at that point in time.
I mean, what I was really getting at with my question is just that I'm anticipating you had a lot of challenges recanalizing this, that it's probably heavily calcified, and just wondering what kind of stent result you have if you were to look with IVUS. Wondering if you had looked beforehand, if it might have changed.
We did not put the
objective
IVUS,
therapy.
I did not take out another IVUS catheter and put that down there after the stented.
Did you consider doing intravascular lithotripsy?
We did. We had, because we're in the subintimal space, we had decent expansion, and so we felt that we were going to have an optimal result with stenting and didn't take out an intravascular lithotripsy device.
So Shirling, you would do intra-IVL in a subintimal space? I'm asking, there's nothing wrong. I'm not saying you shouldn't, but will you do it?
I think, well, first of all, I never feel like we cross in the true lumen all the time. I think when we think it's true lumen, it is partially true lumen, and some of it is probably not. But we do shockwave all the time in those. And I think even in something like this where we're probably subintimal, I would probably do shockwave also. Other thoughts on that?
Subhash, do you think there's a risk there, or there's just no benefit? If you were to do IVL,
I think
and you
you
were to be
lose
partly
some
or
of the
completely
benefit
subintimal.
because
I mean, this is just a thought we can discuss. I think when you create, in my opinion, a long, substantial subintimal tract, the purpose of a scaffold at that point, I mean, not ideally to hold that space open. I mean, there would be good logic to put a regular balloon and expand it and see in two projections, but I wasn't sure if IVL per se would be anything beneficial unless you're paid by the government.
Can you go back to your picture, the last picture? The only other thing I'd say is, if you're going to go put a scaffold here, if you look at 30, on your tape. By the way, I love the tape being there. I think we should all do it. But I would say if you're going to treat a calcified lesion like this with a scaffold, the better scaffold is an interwoven stent, bar none. And you can do whatever you have to do, whether it's IVL, subintimal, or more aggressive, or paving crack, whatever you need to do. But I think the failure mechanism here is going to be what you see at 30. It's going to be hard to expand a nitinol stent fully against aggressive calcium. And I think interwoven, this is why it's an indication to consider interwoven stent.
That's a great point, especially on the last talks.
I agree. I probably would have used IVL and gone to a Subhash stent at this point, and maybe some DCB there too. I don't know. I mean, you're probably subintimal more than most, but throwing some additional, I'm going to run up the cost here and put them all in there and see what happens.
Yep. Okay, great points. Just quickly here, I'll leave this up for those who aren't familiar with Pioneer device, but remember it's IVUS guided reentry, so you orient the ChromaFlow at 12 o'clock. Always try to use a non-hydrophilic wire. Sometimes the device can get really sticky over that, so a supportive non-hydrophilic wire is best to use through that needle. So we'll go on to the next case, which we'll say is go over or go through it. So this is a 54-year-old Hispanic woman, ESRD, who already has a BKA on the right and has had prior interventions on the left, in-stent restenosis in her coronary stents as well, and is now here with a non-healing wound on her left first and second toes, and had a failed attempt at an outside institution. So she was transferred for a second attempt and second opinion. Here is her inflow and diagnostic angiograms. So she has a mid-SFA 100% occlusion, and I can tell you, and I think I have it on the next slide, so she reconstitutes not until the AT vessel. I think here. She has a previously placed supera stent through the popliteal, and then another stent presumably into the PT. Not sure where it interacts with the TP trunk. And oops, did those not play? So, and then here's her, thank you for doing that in the back. So her runoff, she really only has single vessel runoff, but a pretty healthy AT all the way down to her foot. So we paused at this point in time. We took her off the table and had a conversation with our vascular surgeons, right? Because while not perfect as far as a patency rate, if she does have adequate vein for an across-the-knee bypass to a relatively healthy AT vessel with adequate, I don't know, Shirley, is this adequate runoff to support that? If she had adequate vein?
I think I think that's the right. I mean, if she has good vein, a femtibial bypass here is a great option.
Right.
I would think so. Looking at that, okay. I would think so. I mean, really, it would depend on whether the vein was good.
Right. And unfortunately, it was not.
Unfortunately, I don't know who did it, and we weren't there.
Nope.
But somebody stented across the best vessel she had.
Correct.
The anterior tibial. You probably could still go retrograde and get there, and probably still could fix this, but you know, it's a shame that you got these long stents, including some pretty small ones in the TP trunk and posterior tibial.
Yep.
Maybe they left that magic hole between. There's a little tiny gap there. I doubt it. But we've stented across the best vessel she had.
Yeah. Unfortunately, I agree. And so I wanted to take an antegrated first approach after we had all talked. I was a little afraid of doing damage to the only vessel she had as runoff, and knowing she already was a critical limb ischemia, I figured I'd at least try antegrade first before I stuck retrograde. So we used a Navicross and a command wire. I was able to navigate pretty well and easily through the SFA and inside the stent. Once we got to the stent, we were unable to advance the 035 Navicross, so we used a mother-daughter technique where we brought an 018 Navicross through the 035 to give us additional support. So just another tip and trick to try to cross to give yourself more support. And then working in orthogonal views and making sure we were inside the stent, we were able to advance this wire and those microcatheters. And then we're really careful as we re-entered into that distal cap, trying not to disrupt or dissect further down the one good vessel that she has, right? So why did it fail? I didn't include all the IVUSs here, but I can tell you that so the first thing we did was IVUS. This is an undersized supera stent. It looked like it was about a 5.0 stent in like a 6.0 vessel. And it had very aggressive intimal hyperplasia as well. So, And then she also has poor runoff, right? So that's part of the reason that stent probably occluded as well. So we opted to use laser at that point in time, knowing that it was both underexpanded or undersized and also had intimal hyperplasia. So we lased through the SFA, through the stent as well, and then really aggressive serial balloon inflations with non-compliant balloons. I did not use a cutting balloon, and then unfortunately had a dissection in the SFA, so we ended up having to lay stent proximally, but you can see our final results here at the end. She did go on to have demarcation of her wound and was able to have debridement, and so far has been progressing and healing in the way, as we would hope. So this isn't going to stay open forever, but hopefully it's going to not leave her with bilateral BKAs is the goal here. Would anybody have done anything different here or used more aggressive techniques or different techniques?
I think you did what you could. I will say this for the audience. I love Separas. In 2007, I started doing them. Somebody convinced me that 4.5 and 5s were a good idea. I will promise you to the audience, I don't even have them on the shelf anymore. Maybe for a TP trunk or something, but if you put a 4.5 or a 5.0, you've created a monster that cannot be long-term defeated with endo. So your best mode is to clean it out, not put anything else inside of it, and DCB and hope. But I would have a very frank conversation with that person. You're likely to come back. It's going to go back and back. I've finally outlived the few mistakes I did there. Something happened along the way, but they keep coming back and back and back. So small Separas, just like any small nitinol
Exactly.
is a bad thing. You did what you could here. I think it's a good result, and they're going to heal wounds, and then you're going to start thinking about your surgical or other options if it keeps coming back.
Yeah.
So, sorry, Shirling.
Oh, I was just going to say if there were any other questions, if Dr. Feldman had a comment, I saw him raise his hand, or if he wants to come up and give his next talk.
Let's do it.
The later.
Latter.
So while he's
Thank you, Dr. Rosso. Great cases. Great cases.
So while he's coming up, I'll throw something provocative out. I used to think that you couldn't do orbital atherectomy in stents, right? But I've seen it a lot, and I've seen it work a lot. And my question to you would be, would you consider doing that to this stent?
No, heck no, and super heck no. The mechanism, orbital atherectomy embolizes more than anything, and it's for calcium. So would I put an orbital atherectomy in? No, I'd pick any device but orbital atherectomy personally.
Yeah, I mean to ablate your stent.
What?
To ablate your stent.
I don't think you're going to ablate it. I think you're going to maybe get it stuck somewhere or do something bad. I wouldn't.
That's an F no for me. So yeah, no way.
He's
Like
not
I
the
said,
gentleman that I
provocative.
am.
All right, so last but not least, so my topic was Fempop Revascularization with facilitated reentry, and as you can see, the prior talk already touched on this quite a bit, so hopefully we will get through this fast. No relevant disclosure. So this is a patient that I've been taking care of for many years, 76-year-old man, all the regular risk factors, hypertension, hyperlipidemia, had coronary disease, very extensive PCI to the RCA, the whole RCA and RPLB have been stented, was a prior smoker. After the PCI, he finally quit smoking. So one good thing. Developed right lower extremity claudication for a couple of years. On exam had decreased pulses. His ABIs were 0.7 with a drop in ABIs with exertion in right lower extremity. The velocities were over 300 in mid-right SFA. So we took him for an angio. You can see he has a small infrarenal abdominal aneurysm, mild iliac disease. The proximal right SFA is mildly diseased. The arrow shows that there is a eccentric, not very severe angiographically, but eccentric calcified lesion in mid to distal SFA. The rest of the popliteal is mildly to moderately diseased. There's a good 2-vessel runoff. We ended up treating this with orbital atherectomy. This is going a few years back before the IVL. Finished with DCB, got a good result. We took pictures of the other leg, the left lower extremity. There's, as you can see, mild proximal SFA disease, where the arrow is in the distal SFA, sort of calcified, diffuse disease, which is maybe even more severe than the contralateral side, with a decent 2-vessel runoff.
But the patient did quite well in terms of the initial intervention, was placed on aspirin, ticagrelor for concomitant CAD and PAD. We left the left lower extremity alone. It was essentially asymptomatic, but 1 year later it became symptomatic. And now the sonogram showed that the left SFA is occluded. The ABI was 0.7. So we brought him back. As you can see, the imaging, the angiogram, the proximal SFA is still sort of diffusely diseased. It's a still image, and I hope you can appreciate where the arrows are. There's now a short, relatively short distal SFA occlusion with a concave proximal and convex distal points of occlusion. The popliteal, as you can see, sort of mildly to moderately diseased. There's also progression of disease below the knee. If you look at Dr. Mustafa's classification, or CTOP classification, this meets the type 2, the concave proximal convex distal, which happens to be the most common configuration for a SFA occlusion. So I'll ask the panel to comment what the next steps would be. There's a few options here: antegrade, retrograde approach, simple wire catheter technique, crossing device, dedicated CTO device approach, and we'll go from there.
I understand the classifications. I'm kind of like, I'm going at it from above. I mean, call whatever you want, class 1, 2, 3, 4. I'm going to try it from above with I'm going to try it at 014 initially, because I think we know now if we can try to stay intimal, that's the way to go. So I'm going to try that first.
Yeah, I would try from above also. I would, similar to Dr. Metzger, I would prep the foot at the beginning of the case, because it is very painful to prep the foot mid-case. Yeah. So I would just prep it at the beginning of the case, try from above, stick with the 014 system, not because I think it's going to be true lumen, because I'm convinced it's not, but only because it will make a smaller false lumen channel. So when you're trying to get back in, maybe it might be a little less problematic.
Yeah, agree. Antegrade and wire catheter.
All right.
Yeah, in short CTOs, you'll never, I do a lot of live cases, I never will do a short CTO as a live case. They tend to be more difficult than long ones when you got a bunch of branches. So I'd get a bunch of obliques, and then, like you said, prep the foot so your staff knows. We maybe do one retrogrades from the beginning.
Okay, perfect. So I like, Dr. Banerjee published a very nice manuscript, which everyone should take a look at, in 2019, looking at very systematic sort of approach to this lesion, depending on the lesion length, going from the shorter ones, less than 50 to 150, et cetera, and then looking at the anatomy, whether the anatomy of the occlusion is favorable or not. So tapered proximal cap would be a favorable anatomy, tapered proximal cap with suboptimal target vessel, depending on the size, how well you can visualize, etc. And so this meets a type 1-8 criteria, and we don't have to go into the numbers, but the bottom line, as all the panelists said, this is a favorable criteria, and you would want to try antegrade here. So this is the algorithm that Subhash has proposed, and I think it still stands the test of time. So when you're deciding between antegrade and retrograde, you want to answer a few questions. These are not all the questions you want to answer, but these are the helpful questions that you want to go through, whether you have a blunt or ambiguous proximal cap or a CTOP 4 classification. And if the answer is no, you're more likely to go antegrade. Do you have suboptimal target vessel? And if the answer is no, more likely go antegrade. Appropriate distal access vessel for retrograde access. Is this a CLI patient or not? Not. In this case, this is a claudican. And so if the answers to all 4 of those is no, typically antegrade is going to be your approach. And then depending on the length of the lesion, on anatomic criteria, on the experience of the operator, on what equipment you have in your lab, you can decide whether you want to do simple wire catheter technique, whether you want to do a dedicated CTO device, etc. And of course, there's no shortage of CTO dedicated devices. I'm not going to go through this. There are certain devices like Front Runner that utilizes the actual jaws to blunt microdissection. There are devices like Crosser that uses high energy vibration, which you can put right over the proximal cap to penetrate it, etc. Wildcat that does a rotational cutting. So in this case, as the panel suggested, antegrade wire escalation was attempted. I sort of started with a glide wire, gold tip glide wire 018, wasn't able to cross, and then kind of de-escalated to 014 system with Miracle 6, then Confianza Pro 12 wire. wasn't able to cross, then went further with 018, the high torque connect wire, which has quite a heavy tip of about 40 grams, and still was unable to cross. And so I've tried different orientation, catheters angled, unangled, different tips of wire, etc. So let's see if this is after trying to cross the lesion with multiple wires. And as you can see on the left, you kind of think there's maybe a channel and you can sneak a wire through, but despite multiple attempts, and this is the picture on the right is after a few more attempts, still was unable to cross. So what next? I'll
Retro.
okay.
I think you have to.
I think you're stuck on retrograde at this point, unless you're gonna go prolapse a wire. I think if you have the foot prep, go retro.
Okay.
I think you're going to go retro, and either you're going to get through or you're going to have to rendezvous.
I agree, retrograde.
Yeah, okay. See here, if you follow, and I just follow what Subhash tells me to do. So don't blame me for this case. So you got a few options. You can always switch and go retrograde, but I think you also can consider doing re-entry, right? You still, if you're in a good position, if you're parallel to the vessel, if you're close enough, and you think you can safely re-enter without sort of dissecting too far, that's still an option. And the prior case has demonstrated, a few of these devices. The Pioneer device, you have a few options here. The Outback re-entry is sort of the simpler methodology. You have a 7mm needle within a catheter. You can orient the catheter in sort of at least two orthogonal views. You want to make sure on the right side that you're pointing towards the vessel. You want to make sure you're close to the vessel. You also want to understand that the needle is 7mm, so where the needle comes out and where it's going to enter has to be close enough to where exactly you want to be. You don't want to dissect with your wire too far, and you don't want to re-enter too far down. So that's what I did. I used the Outback re-enter here, past a small catheter. You can see this is the injection on the left side through that to make sure that I am in the distal vessel. I do have to agree, and I think the panelists will comment on that. I think I did re-enter a little bit further down where I wanted to. So I think going retrograde in retrospect was certainly an appropriate suggestion. Followed this by the balloon angioplasty. On the left side, the playing image, you can see that, I was certainly subintimal, we knew that. The vessel was quite dissected after the plain balloon angioplasty. So with imaging, I didn't think with DCB I was going to get sufficient enough or good enough results. So finished with a DS, left some popliteal disease behind. Below the knee, vessels are still as, you can see one good vessel and a couple of very small diffusely diseased vessels. So a couple of points. Femoral popliteal occlusions, we all know this, very common. Over 50% of your peripheral lesions. The calcium is very common. I like the systematic and algorithmic approach that Subhash, Dr. Banerjee proposed. You don't have to follow it to the letter, but it helps you to approach antegrade versus retrograde and pivot when you have to. But the key, I think, here is understanding what your crossing strategies are, understand different wires, how to wire escalate, what wires you're going to use. You don't need to know all the wires. CTO crossing devices, you can certainly have expertise with some of them. You don't need expertise with all the devices. But re-entry devices are going to be key for femoral popliteal CTOs. And so knowing when to use them and when not to use them is going to be essential to the success. The other points have been touched on. You have to assess lesion morphology, calcium, especially when you're not sure. Imaging is going to be key. True lumen versus subintimal, I would say there are benefits to going true lumen. I think you can be more aggressive with atherectomy. You can avoid stenting in many cases. But I would say you don't have to be married to true lumen. If you go subintimal and you can safely re-enter, I think the bottom line is you want to get the case done effectively and safely. And then what's going to keep the patient happy is the long-term patency. And so you have to think about what drug you're going to use, whether you're going to use scaffold or not, and the long-term patency is going to be very much dependent on that as well. All right, I'll open for the discussion. Thank you.
Dimitry, thank you very much. As we're closing the session, and Dr. Tsai is going to close the session, a quick announcement and a reminder to everybody that tonight is a CVI gala at 9 o'clock on in the restaurant on the ground level floor. There will be food, open bar, and an amazing band. If it's a band, what I heard that was here a couple years ago, it's a Motown band. They're phenomenal. Any ladies that want to drag me on a dance floor, two methods work: twisting my right arm or buying me a drink. But anyhow, it'll be a lot of fun. I would encourage everybody to be there.
Yeah, everyone come. Hello? Okay, everyone should come to the party tonight. It's great. We can all go dancing, which will be a ton of fun. And that was a great case, Dr. Feldman. Thank you so much. And thank everyone for coming to this last session. I know it's late in the afternoon, but thank you all for staying. And have a great evening. Thanks.